Hello, welcome back to Advanced Human Gross Anatomy. Today, we have an extensive dissection. Today, we've completed in our study so far the thorax, the abdomen, and the pelvis. And now we're going to be spending some time on musculature and structures of the back and the extremities. So we'll take a good, long and close look at these particular structures. Now, the first thing we'll do today is a bit of a dissection. So with the donor prone, you will be taking a scalpel and making an incision at the midline from the upper cervical vertebrae down to about the level of the mid-sacrum, so all the way up and down here. And then you're going to make lateral cuts from the extremes of those vertical of that incision off to kind of come over the pelvis here a little bit on each side, and then kind of down onto the superior portion of the trapezius, the shoulder area here. And then I'd like you to just start to remove, working from the midline, working laterally to remove the skin and the superficial fascia from this area. So make that initial cut with a scalpel, but then try to be cautious here. What I'd like you to do is use a blunt probe and a hemostat to clamp and to pull away and kind of tease that tissue, the skin and the superficial fascia away from the underlying musculature. In your group, you'll work, half of you will be on this left side, half of you will be on the right side, doing the same thing, working from midline out laterally to each side. And you can just remove the entirety of that skin and superficial fascia and put it into the storage bin for safekeeping of tissues. We've already studied these tissues in previous dissections, so I don't think it will be that important to us here to look at those tissues again. So once you've revealed the back musculature, we'll start looking at those deeper layers. Now, the back musculature is divided into three groups. There's a superficial, an intermediate, and a deep muscular group. The superficial group has muscles that help move the upper extremity. That's kind of their job here, is the superficial musculature. They don't really have much to do with the back, other than their proximal attachments here. Their origins come off of the spine here. The intermediate group is two muscles in particular, the serratus posterior superior and the serratus posterior inferior. These are muscles that will attach to the ribs. We'll see these muscles in more detail a little bit later, but their job is basically to assist with deep inhalation, deep exhalation. That deep breath is kind of what their job is to assist with. But on these donors, typically with age, they get very thin. These are actually going to be very difficult to find. They're almost paper thin at this point in these people's lives, and so much so that you might wonder, well, how are these even considered a muscle group, a layer of muscles here? But you got to remember that the Greeks were working with gladiators and people with younger, stronger musculature, much easier to see. So they're still there, but you're probably just going to have to look more for fiber orientation than anything to kind of see. So you've seen this name before, serratus. Remember the serratus anterior that came from that the first 9 ribs coming on the anterior portion of the scapula. These are going to be posteriorly here. So we'll take a deeper look at that later on as well. And then you get to the deep group. Let's see here, I can show you the deeper group. Here's probably a better shot of that serratus posterior superior and serratus posterior inferior. The deeper group of muscles are muscles that will move the spine itself. These are called the erector spinae. So we'll see some muscles up in the neck here, the splenius capitis, the semispinalis capitis, but then there's this group here, this erector spinae, that we'll talk about with some detail later on as well, the spinalis longissimus and iliocostalis on each side. And then even deeper to that are some other muscles, the transverse spinalis musculature, the rotators, here's the rotators, the levators, underneath the multifidi. These are more for stabilizing and moving the vertebrae themselves. So we'll take a deeper look at those later on. Let's continue now with some bone review, some bony review. So muscles turn into tendons and attach to bones, so it's good to have some awareness of these attachment sites. The first one, the occipital bone, here's a couple of interesting things on it. One is called the inion, I-N-I-O-N, or the external occipital protuberance, this big bump here. I think it's easier to see from a side view here. You can see that bump. You can feel this on the back of your own head if you just kind of go up from the spine of the vertebrae and kind of work your way up onto the head. There's a kind of a ridge there, a bump. That's what you're feeling right here. Off to the sides of that are these neutral lines. You can see these ridges of bone that go laterally on each side of the occipital bone from the inion here. Here's an inferior neutral line and a superior neutral line. These again are just for where groups of muscles will attach to the bottom of the occipital bone. Another bone that's going to be interesting will be the temporal bone here. So on the skull, the temporal bone right here. There's a bump on the backside right behind your ear. You can feel this as well, a big bump here called the mastoid process. That will be for attachment sites of a couple of important muscles here, the sternocleidomastoid in particular, and other spine musculature comes up and attaches to the mastoid process. But let's spend some time looking at the scapula. This is just another a bony attachment site. There are 18 different muscles attached to each of your scapula. I believe 18, 22 different muscle attachments of those 18 muscles. So it's a large muscle hub, a big attachment hub here for musculature. If you feel back on your own scapula, the big ridge you feel on this bony ridge is called the spine of the scapula. When you were little, maybe you thought that was the top of the scapula. That's not actually. The top is buried under some musculature that we'll see in a little bit. But that's the first part here. A good site for muscle attachment is the spine of the scapula. If you continue that spine off towards laterally, towards the edge, you'll find the acromion process right here. The acromion process is where the clavicle attaches on the front side. Here you can see just on the model where that acromion process attaches to the clavicle. That's actually an important structure anatomically in the upper extremity where the arm attaches to the clavicle, because the clavicle's attachment to the skeleton is right further down here. But that's a common pathological site, that AC joint, the acromioclavicular joint. There's a superior angle right here, which is for muscle attachment. We'll see later on. If there's a superior angle, there's an inferior angle down here. Which you can see. There's also a medial border, also called a vertebral border on the inside, medially. This is obviously the right scapula. Now here's a lateral border, or a axillary border on the lateral side. There's above the spine, you've got this fossa. What do we call a fossa above the spine of the scapula? Maybe the supraspinous fossa. It's above the spine, but it's a fossa above the spine. The supraspinous fossa, a muscle that we'll learn of the rotator cuff that sits in there. Below the spine, the infraspinous fossa, below the spine, where a muscle will sit inside there, which we'll learn later on. Let's see, then there's the coracoid process on the top side here, this little hook, this little finger-like hook. It's in Latin, it literally means beak. Coracoid means beak. Maybe here's a different shot of it from the anterior side. You can see how it kind of sits out in front like that. That's going to be a muscle attachment for the pectoralis minor, an insertion of the pectoralis minor, and then the origin of the short head of the biceps. So that one muscle is an insertion and an origin. The muscles that attach to this part of it will help stabilize the scapula to allow the other muscles to move the upper extremity. So you have to have a place that's stable in order to move other things from it. So since the shoulder blade is just kind of floating around the rib cage, and the arm is just kind of sitting in the socket of the shoulder blade, nothing's really attached to the body until that collarbone, the clavicle, attaches to the sternum. And so you need to fix the scapula in place in order for musculature that attaches to the shoulder blade and arm to move more appropriately. You have to have a base that's stable. So some of this musculature, like the short head of the bicep and pectoralis minor, are going to be scapular stabilizers. So we'll talk more about that when we get to the upper extremity too. Looking at the pelvis, just a couple of quick things to look at here. Remember the ilium, the crest of the ilium up here, not your hip. Put your hands on your hips. That's not it. This is the ilium. Simon says put your hands on your hips would be really pretty disruptive to a lot of tissue if you had to put your hands on your hip joint. But the crest of the pelvis is okay. So the crest of the pelvis, as you follow that back, you'll find these two bumps on the back of the ilium here, the posterior superior iliac spine, the PSIS. We'll learn later on with the lower extremity, the ASIS, the as-is bone right here. A little bump on the crest of the anterior and posterior portions of the ilium. Now, if we look at the skeleton for a second, the vertebrae, so the vertebral column are just a bunch of vertebrae stacked one on top of another to create this column that you see here. So they just kind of stack together and they create this curvature. In adulthood, we'll talk about the curves later on, but they create this ability for structural stability through an axial load, gravity pushing straight down. So the first 7 are the cervical vertebrae, C1 through C7. They're smaller in size because they bear less weight, just the head sitting on top, so they can be a little smaller. The thoracic vertebrae are T1 through T12, the 12 vertebrae of the thoracic cavity. These are associated with the ribs. They help protect the thorax, the upper part of the abdomen, the rib cage coming off of the thoracic vertebrae. And then the lumbar vertebrae 1 through 5, L1 through 5 down here. These are much bigger. They support the load of the trunk, anything above it, and partly support the posterior aspects of the abdomen on the backside here. And then the sacrum is this set of five fused vertebrae. Early in life, after birth, these 5 vertebrae fuse together to form this triangularly shaped bone at the bottom. Okay, we've already talked about the coccyx with the pelvic floor, so we won't get into that. Now, lots of things going on here when you look at a vertebrae. So we can look at, let's look at maybe this picture here. So the kind of the classic vertebrae here, this is depicted as the second lumbar vertebrae, but that's fine. We'll just use it as kind of just a standard example of the vertebrae. So the first thing you feel as you look down the spine, let's go back to this one here. So from a posterior view, when the body is prone, you can feel these bumps if you follow right down. This is where you cut right down the spinous processes. But if we go back to here, you'll see that spinous process sticking straight out. Okay, so straight posteriorly is the spinous process. Lateral to those are going to be the transverse processes on each side. So here's a transverse process, here's a transverse process. And then you have the space you can see between the body of the vertebrae here and the body of the vertebrae here. There's a space. The intervertebral disc sits inside here. And this is here's a shot of a disc that's just kind of sitting out on its own here, but it has a nucleus on the inside and then all sorts of fibrous rings of tissue around it to give it some structural support and stability. And that fibrocartilage pad here, that disc, is for spacing. So you can see how it spaces the vertebrae. It's also a good cushion, a good strong fibrocartilage cushion for the loading, for when you jump and stand and land onto your feet. That pressure going axially up through the spine creates that ability to withhold that. The intervertebral foramen, you can see here, the top vertebrae kind of makes a little arch right here. The bottom vertebrae right here before the facet joint makes a little dip. So when you put those together at the facet joints, here's a superior facet, here's a superior facet, inferior facet. When you put those together, they create this hole laterally. You can see this from the lateral view. They create a hole, and that's where the spinal nerves are going to exit out of the spinal cord. And so when you have a disc that's herniated, potentially from a trauma, maybe a car accident or something very aggressive or abrupt, or it could be just small insults over a period of time as the bodies of the vertebrae maybe anteriorly are getting compressed, pushing that fluid of the nucleus pulposus, weakening that surrounding annulus, and then you can get like a bulge here or a herniation, but it's going to go backwards. It can't go straight back because the spinal cord's in the way, but it's got to pick a direction. Usually when people have a disc herniation, it's going to go back, but then it's usually going to go left or right. It's going to pick a direction that it will pinch. Now, if it goes backwards, it could kind of put pressure on or take up space where that spinal nerve is exiting, and that can give you some sensation or motor changes down wherever that nerve goes. But if we look back up at the cervical vertebrae, now the cervical vertebrae are unique in a few ways here. One is that there's this ligamentum nuchae, this big ligament that comes from the nuchal lines and goes down the spine of the spine, go right down into the spine of the vertebrae, the spinous processes. So the spinous processes are forked. Probably easier to see through here. Here's the spinous processes of the cervical spine. You can see how they're forked like this. That's what that ligamentum nuchae is going to attach inside of those of the spinous processes like that. So C1, you can see here, doesn't really have a body, but C2, 3, 4, 5, 6, and then the first vertebrae you get to that you can actually palpate from the outside is C7. Now, a lot of people think that's the first one I can feel is C7, vertebra prominens, this Latin for prominent vertebrae. I believe that you can actually palpate deep. You can kind of push that ligamentum nuchae in and feel some of the bumps here where the spinous processes would be. You can certainly feel the transverse processes, the articular pillars on the outsides through here. But some people say that ligamentum nuchae, the first vertebrae you can feel is the big one here, C7, and that's fine. I guess I'll buy that too. Although I feel like I can palpate some of those middle or lower cervical vertebrae through the ligamentum nuchae. They also have let me show this picture again here. You can see they have a transverse foramen. This is this hole in the transverse process, and this is where the vertebral arteries will pass through on their way up. Here you can see that vertebral artery coming from the subclavian artery, going up through the transverse processes, through that transverse foramen of the transverse processes, coming up to C1. Through C1, it makes a 90-degree angle here, and then makes another 90-degree angle up, where it joins up with the other vertebral artery from the other side. They join up through that foramen magnum of the occipital bone near the end of the brain stem, where they'll form the basilic artery and so forth. We'll get to that later on, but that's right up through here. So this is why some people get nervous with cervical thrust type manipulations of the upper cervical spine, because that artery is already a little kinked there, and you don't want to put too much load and pressure through there for any given period of time. But we can discuss that in lab if you like later. I have thoughts and opinions there too, like everybody. But there are 4 vessels that feed the brain. So 2 are the vertebral arteries, 1 on each side, and 2 are the internal carotids, 2 on each side. So those 4 arteries are the only hoses that you have bringing nutrition to the central nervous system. So that's kind of or to the brain. So that's kind of a big deal. That's kind of a big deal. The first vertebrae is called C1 here. This is a unique vertebrae in a lot of ways because it has no body. You can just see you look at the rest of it. Let's go back to this. This is a classic vertebrae. Here's a thoracic vertebrae. It's got the spinous process, the transverse processes, and it's got this big body here. The cervical vertebrae number 1 does not have that body. The body of C2, you can see here, has this projection. It's called the dens, or the odontoid process, that comes up and almost acts like the body of C1, but it kind of sits right behind C1 here, and where the body would be, the anterior portion here, rather, where the body would be. And that's where C1 can kind of swivel, can turn on C2. About 50% of your rotation in your cervical spine comes from C1 rotating on C2, around that dens, or the odontoid process. This is what makes just by the way here, dens or odonto, those 2 words literally mean tooth. So it kind of looks like a tooth kind of sticking up there, right? But this is a potential issue for trauma. If you were in a motor vehicle accident, it's a common accident that can happen where it can disrupt or dislodge or kind of fracture this odontoid process from the body of C2. And now you've got a potential loose body right in front of the spinal cord. So that can be dangerous. Whiplash associated disorders and such. So this is why when you come upon a trauma scene, you need to stabilize the head, because you don't know without a scan here what's going on. What is the integrity of that dens on C2? Has it disrupted? Is there a compromise potentially at the spinal cord? You know that the Greeks love their mythology. Another name for C1 is called the Atlas. Remember Atlas, the Greek god who literally held the earth on his shoulders. This is kind of, if the head was the earth, this would be Atlas holding the earth above. Axis makes sense. So the Atlas and the axis, C1 and C2, axis being that pivot point for C1 to rotate around. Okay. We've talked a little bit already about the vertebral. We've talked about the intervertebral foramen. Here again, you can see the intervertebral foramen between the vertebrae where the spinal nerve exits, between two adjacent vertebrae. But then you've also got this vertebral foramen. Now, the vertebral foramen is just in a single vertebrae like this. It's just the hole where the spinal cord would be. It's posterior to the body. It's anterior to the spinous process is this vertebral foramen. Now, if you stack a bunch of these vertebral foramen one on top of another, now you have a vertebral column. This is where or the vertebral canal, rather. This is where that canal is where the spinal cord will sit. The vertebral column is just a bunch of vertebrae stacked on each other. The vertebral canal would be where the spinal cord sits. If you just take one out, the whole is just a vertebral foramen, the whole where that sits. Now, a couple more portions of the anatomy here that will come in handy later in this dissection. The spinous process we've talked about, the transverse process we've talked about. The space here between those is actually called the lamina on each side. The space between the transverse process and the body, so right here and right here, that's called the pedicle. Pedicle means ped means foot. So that's where the foot is going to be here. So that makes up this vertebral arch: spinous process, lamina, transverse process, pedicle, body, pedicle, transverse process, lamina, spinous process. It just goes around and around. Now, in today's dissection, we're actually going to be removing the lamina of several vertebrae coming down. And so coming down kind of between the shoulder blades. I'll talk about that in a little bit here. But so we'll be removing the spinous processes by cutting through the lamina on each side. We'll be doing laminectomies, removing the spinous process on both sides of both lamina. So we'll first have to cut through the musculature on the top, through the multifida and the deep rotators, and then we'll take a chisel and with a hammer and kind of break through the lamina on each side, being careful not to go into the spinal cord, and trying to pry that lamina and the spinous process free. We may need to get a nippers to kind of cut, here and here to give a little encouragement, but removing the spinous process and the lamina will expose the spinal cord underneath it, as well as the dorsal and the ventral roots going in to make that spinal nerve. So this first spinous process you'll feel will be that C7, that vertebral prominence. So we'll kind of go later on. We'll talk about going down and how to do that later on. Let's talk briefly about spinal curves here for a moment. Now, the spinal curves are interesting because when in development in the womb, we had one primary spinal curve. That's it. It was concave anteriorly, this concavity anteriorly. So the head being up here, the cervical spine, the thoracic spine, the lumbar spine, the sacrum, kind of all curved like this. And what happens is in development, the first thing you're going to notice is that when an infant starts to get strong enough, they start to develop, they start to be able to lift up their head. And when they do that, they're having some tummy time and they lift their head up a little bit. They're developing here the secondary curve, the cervical curve. That'd be the first curve to kind of recurve itself into an opposite direction of the primary. So that we call these secondary curves, the cervical curve. The lumbar spine is the next one. As you start to sit up, you start to load weight through your pelvis, eventually standing. Then you start to develop this lumbar curve right here. So the secondary curves. Primary curves refer to where you were in the womb here. The thoracic and the sacral curves are primary curves. They maintain that concavity anteriorly. But the lumbar and the cervical curves are what you develop as you become more upright and resisting gravity, first with your head, then with your lumbar spine, coming down like that. Now, these are also common sites that will develop trouble later in life, the cervical and the lumbar regions. A lot of people have herniations at these end ranges. Part of that is because they're at the ends, because they're more mobile. You're always more stable in the middle of a structure. Part of it maybe is that these are just secondary curves that you've learned to develop over time. So these they allow the most motion and obviously the most potential for disruption or dysfunction. So what I'd like you to do now is looking down. Let's look at this picture here. One of the things we'll do before we get into the deeper musculature is try to find one particular artery and nerve. So you're going to remove the skin from the bottom part of the occipital bone. So kind of up by that neutral line, where the musculature, you'll see where some of that musculature is joining that neutral line up here. You can kind of dissect down, take a blunt probe and dig around a little bit, and what you'll find is this, the first one you'll find here is this occipital artery kind of coming up. You'll find it ascending on each side, you're kind of going up this way. Now next to that you'll also find this greater occipital nerve. So the occipital artery and the greater occipital nerve actually coming from the dorsal rami of the cervical spine. The greater occipital nerve is coming from the dorsal rami of the cervical spine and giving sensation on the back of the skull, kind of on each side through here. So you can kind of identify that. They should be pretty easy to find, that occipital artery and the greater occipital nerve on each side. Okay. Now let's start talking about some musculature. Your favorite, I hope. All right, now when you're talking about muscles, what's important here is to get some understanding of their name is going to be important, and their attachment sites. Where do they come from? Where do they go? Where did they come from? Where do they go? Cotton Eye Joe. So the musculature, if you can learn those three things, name them, there's going to be a lot of clues often in the name of the muscle as far as where it comes from, where it goes, what it does. These aren't cleverly named, a lot of them. So once you start getting the clue of why they name it that way, or what's interesting about this tissue, that might give some help. Then the next part is, where on the skeleton do they attach? So when you anchor something, the anchored portion, more proximally, we're going to call that the origin. And then the moving part. If a muscle is going to have an anchoring center point here, it's also going to have a point where it's going to move. And so the moving part, and more distally, is typically called the insertion. Now I learned these as origin and insertion. I think that's still a very popular way to learn this, although I'm learning that there's people are using the word insertion for both more and more, a proximal insertion and a distal insertion. I think that's fine. It might be even a little easier. I don't really care how you talk about that, but as long as we're getting the idea of where does it come from on the skeleton, where is it going, and then if you bring the insertion towards the origin of any muscle, you know what it does. So you don't need to memorize what it does. If you can know what is it named, what's the name, where does it come from, where does it go, you've already got the action if you just shorten the origin toward the insertion. It works pretty well. So first thing we're going to look at here is the superficial group here, the trapezius. Now you know the Greeks loved geometry. So trapezius, a trapezoid, right? Trapezoid is just like a triangle with the top cut off. So you can see this kind of trapezoid structure here. It's got the trapezius has a large origin, way up from the occipital bone, all the cervical vertebrae, down to the lower thoracic vertebrae here. That's the origin, or the proximal insertion of the trapezius. Now the lower portion is going to insert on the scapula, the kind of the lower third of the scapula down here, maybe to the spine. The middle portion is just going to go right to the middle of the spine of the scapula, or the medial border. And then the upper portions are actually going to go down to the clavicle and to the acromion process, kind of up in through here. Now, this functions both as an elevator and a protractor and a retractor of the scapula. We'll talk about that in just a second, but it's a unique portion. The upper trapezius is going to be this elevator and protractor. It's going to kind of bring the shoulder blade forward as it lifts it towards the ear. The acromion area. The lower trapezius is going to bring that inferior portion of the scapula down, so it's going to retract and depress the scapula down and back. So that's a unique thing. This one muscle will be both its agonist and antagonist. It's going to bring the scapula up and forward and down and back, depending on which fibers are being activated. Now, what makes this even more unique is that muscles that help move the upper extremity are generally innervated by the brachial plexus, C4 to T1, all the musculature up in the arm. Typically, anything that's going to move the arm, usually you think brachial plexus. But the trapezius is unique in that it's innervated by the 11th cranial nerve, the spinal accessory nerve, in the brainstem. So that 11th cranial nerve comes down and tells the trapezius, also the sternocleidomastoid, those two muscles, what to do. But the trapezius, one muscle, innervated by one nerve, a cranial nerve, lifts the shoulder blade up and forward and brings the shoulder blade back and down. Amazing. Odd, complicated, all of those things. Now, the other part of that superficial group is the latissimus dorsi. This, again, extensive origin from the thoracic vertebrae way up here. You kind of see it tucking under the upper trapezius. Down, it's going to come all the way down to the sacrum, the sacral vertebrae, off the iliac crest, even coming up this way. And its fibers are going to converge. Now, obviously, on each side, it's dissected off of here. As you can see, it's reflected back to dissect down. But let's just look at the left side. It's going to converge. These fibers go underneath the arm. And it's going to attach into the intertubercular groove of the humerus, on the anterior side of the humerus. So what is that going to do? It's going to bring the humerus, the anterior portion of the humerus, it's going to rotate in as it brings the arm backwards, right? So it's going to bring the whole arm back. So it's going to function to extend the arm and internally rotate the humerus. Okay. Now, in swimmers, I think of swimmers when I think of lats, like these Dorito-shaped bodies, right, where the latissimus comes way out like this. You can see kind of that triangular-shaped body, or cobra, maybe you called it. That's what I called it when I was little. But I like the idea of a Dorito-shaped body, these lats that come way out to the side. But think of a swimmer reaching, catching that water. If you think of a freestyle stroke or a front crawl, catching the water, internally rotated at the humerus, and then extending it, pushing kind of in that catch and pull phase of the swim stroke backwards, pulling that musculature back. So that strong latissimus. Okay, now once you've dissected back and you've taken the skin off and you've made this look so beautiful, you've dissected it, it just looks like, just like Netter's dissection picture here of the upper trapezius and the levator on each side. Then I don't want to get divisive here, but I want you to decide within your group who did a better job, which is more beautiful, the left or the right. And then we're going to keep the side that looks pretty good, and then we're going to dig around on the other side here. So actually what you're going to do is remove the trapezius and the latissimus on the less desirable superficial side to expose some of those underlying musculature, here. Okay, so let's remove the upper trapezius and levator. Keep levator. Remove the upper trapezius and latissimus, rather, and then you'll start to be able to dissect down. Now, another layer you're going to find here is the rhomboids, the rhomboid major and minor. Now, these are a little bit difficult to tell on these donors, the older donors. Tougher to tell the minor from the major. Minor comes from the spinous process of C7 and T1, coming down a little bit toward that medial border of the scapula, superior angle right here. And then the rhomboid major is going to come from more like T2 to T5 or so, kind of right in through here, and insert onto the medial border of the scapula. So you can see it's a little bit down and out. It's coming this way. So with the insertion being at the medial border of the scapula, it's going to function to pull that more toward the origin. So it's going to retract the scapula and then slightly elevate it, kind of pull it back and up slightly. Another important muscle here is called the levator scapula. This one actually comes off of the transverse processes of the first 4 cervical vertebrae, and it comes down diagonally this way to attach to the superior angle of the scapula. It's going to function in elevating the scapula. So when you shrug your shoulders and say, I don't know, when I ask you a question on the quiz later, what is the answer to this question? And you shrug your shoulders, I don't know. You're using upper trapezius, levator scapula. You're bringing that levator, shortening, bringing the superior angle toward the transverse processes of T1 through 4. Okay, let's look at this picture now for a second. This one's pretty good. Let's start here. So if you look at the back of the shoulder blade now, there's a muscle on the, remember the spine of the scapula? Go superior to the spine of the scapula, and you're going to have the, remember that supraspinous fossa? Well, the muscle that sits in that supraspinous fossa is the supraspinatus. So the supraspinatus, actually, I think this is probably a better view of it here. Here's the spine of the scapula. It's a superior view looking straight down, but here you can see on the right scapula the supraspinatus coming here. It comes, kind of goes underneath, travels under the acromion process, under this ligamentous structure here, and attaches down kind of on the top of the humerus, to the greater tuberosity of the humerus. It functions here, you can see on the top here from the posterior view, going underneath that spine of the acromion process, coming down and attaching on the top here. It acts as an abductor, an abductor. Now, maybe you learn this, the difference between abduction and adduction. That's typically how I say it. Even in the clinic, I'll talk about instead of abduct and adduct. It's just one letter difference, and they sound the same, especially with my nasally voice. Tough to understand me sometimes, I'm sure, but to abduct it means to bring away from midline. To adduct, to adduct, it means to bring toward midline. I think of adding together, add it, adduction. So this is an abductor, an abduction. Below the spine of the scapula is the infraspinatus, sitting in the infraspinous fossa. And that's going to come over from that infraspinous fossa, it's going to come over laterally to attach to the kind of the posterior aspect of the greater tuberosity. Functions to externally rotate. Imagine pulling that greater tuberosity this way, spinning the head of the humerus in the glenoid, externally rotating it or laterally rotating it this way. Just below that, kind of a little brother, if you will, to the infraspinatus is the teres minor. This also comes from the infraspinous fossa, coming over toward that kind of inferior portion of the greater tuberosity, that footprint where the rotator cuff attaches to the head of the humerus here, also acting like the infraspinatus to externally rotate. Now, on the front of the scapula, this is still the right scapula, but now it's just, you're looking at the anterior portion. Here's posterior, here's anterior. The anterior portion is this big muscle that comes from the subscapular fossa. It's called the subscapularis, right? The front of the scapula, which you can see here. This muscle, it comes from here and goes to the lesser tuberosity of the humerus on the front side. So right kind of in the armpit, picture between the back of the rib cage and the front of the scapula. From the front of the scapula coming inside to the anterior portion of the humerus here to the lesser tuberosity, you're going to have this one. Now this is going to be an internal rotator. But look at the size of this. It's much bigger diameter here than it is the infraspinatus and the teres minor. These external rotators don't have as much muscle mass. So here's just a little tip. You get most of the power, if you're going to compare internal to external rotation, comes from internal rotation. So if you're going to arm wrestle somebody, be sure to start with focus on internal rotation of the humerus. That might give you an edge. But think about it, most of the time when we're lifting something, picking things up, we're pushing together, we're internally rotating that arm to get there. So this infraspinatus, the subscapularis gets a lot of work. So those 4 muscles, supraspinatus, infraspinatus, teres minor, and subscapularis, that is your rotator cuff. I've heard an acronym that you could use, SITS, S-I-T-S, supra, infra, teres minor, and subscapularis. If that helps you, that's fine, but their job collectively will be to hold the head of the humerus into the glenoid of the scapula only about 17% or so of that ball of the arm is actually in contact with the socket. So you need a good musculature cuff to help pull that ball, keep it seated into the socket of the glenoid of the scapula. So that can be there. Now, another muscle that I'm going to go back to this picture to see, the teres major. So teres minor is part of the rotator cuff. Teres major, coming from the inferior, kind of the inferior portion of the axillary or lateral border of the scapula, it goes inside. Again, it cuts with the latissimus. It's going to join up here and attach, go on the inside of the arm, and attach into that, enter to that kind of the medial aspect of the intertubercular sulcus, the intertubercular groove on the front side. Can't really see that here. Kind of right up in through here, where the bicep tendon is, and the pec major is going to come up into here as well. But that's all going to come up underneath, and that's going to be a massive, not a massive, but it's going to help the latissimus with internal rotation. So you can see the external rotation from the teres minor, internal rotation because it comes on the anterior aspect in between the arm and the body, more of an internal rotator for the teres major. Minor and major here, don't get that confused. Okay, now if we look back at the intermediate musculature, let's go to this one. Again, these are going to be very difficult to find in these elderly donors that we probably have in the lab. I say probably because, well, I'm recording this without a body in front of me. So typically with an elderly donor, these are going to be very thin, almost like I said, paper thin, very difficult to find. The serratus posterior superior and the serratus posterior inferior. Looking at the superior ones, you can see they come from the spinous processes of C7 to T3, but they come down to the ribs. The inferior, serratus posterior inferior, is coming from spinous process of T11 down to spinous process of L2, coming up towards the ribs this way. So again, I told you they were for inhalation, deep exhalation. Can you tell what they do based on where they are, based on their action? So if the insertion is going to move towards the origin, insertion moving towards the origin, what's the inferior one's going to do? They're going to pull down. That's going to be more for inhalation, right? They're going to be more for these posterior, exhalation. They're going to be pulling the rib cage down, pulling it down, decreasing the volume of the thoracic cavity. The superior ones here, if they're lifting, if they're going to pull up and bring those ribs up and toward the spine here, they're going to be elevating the ribs, opening up that thoracic cavity, allowing more for that inhalation phase. So deep inhalation, deep exhalation. That's going to be the function of those. All right, now the deep group here. Let's just keep this one on here. We can see the three layers, this erector spinae. These are small, relatively speaking, but they function, the deep group here, really, their function is to stabilize and support the spine during movement challenges. So during the day, these are the ones going to hold you together. But the erector spinae, so you can see the spinous processes poking out here, coming laterally from each side. These have been retracted a bit so you can see it a little bit differently, but coming from that gully between the spinous process and the transverse process here, the most superficial of the deep layer is this spinalis muscle. So you can see it on each side, attaching from attaches the spinous processes of the adjacent vertebrae here. And then lateral to that on each side, this is the longismus. This is going to attach more of those transverse processes as they go up and down. You can see they come kind of tracing down the whole length of the vertebral column, coming way up. And then lateral to that yet, on each side, is the iliocostalis. This is going to be more on the ribs, attaching on the rib angles here on each side. So spinalis, longismus, iliocostalis, spinalis, longismus, iliocostalis. That's really what I want you to see there. These are going to extend the spine, keeping it straight with movement. Now, when you're some of you will be working in medical field where you might need to transfer patients or roll them in bed or things like this. When you're lifting, this is what you want to not lift with. Look how small these muscles are. They're pretty puny. They don't have a lot of power to them. Their job is more to stabilize, not force generation. So when you stabilize, you really need to make sure your mechanics are perfect, keeping your spine straight, not putting too much load or stress on these smaller muscles. Excuse me. Now the deeper muscles here, if we go, let's take a layer deeper. and get into, here you can see some multifidi, the spinalis musculature here. Then deeper to that, the semispinalis musculature, you go deep to that, you'll come into the multifidi, which you can see coming down in through here. You go deep to that, now you go on the right side here. Now you've got these rotators and levators here. The rotators come from the transverse process and going to the spinous process, coming up this way. There's a short and a long from the transverse process to the spinous process at the same level, and the long ones will go over to the level above, or 2 levels above, coming up that way. And they function to rotate the spine. So they're going to shorten up on each side here, depending on which side the spine wants to rotate on those facet joints. The levators are actually coming from the transverse processes and going over to the rib or down to the ribs. You can see how it's coming to the rib below or to 2 ribs below, coming down, lifting. They're going to be more for forced inhalation, again, lifting up of the vertebrae, of the ribs, to kind of go more up into that way. Now, I'm not going to ask that you dig down and dissect into these. You're not responsible for that. I'm not going to quiz you on those kinds of things, but I just want you to know that those deeper layers are there. We will have to dissect down. Oh, excuse me. Boy, we will have to dissect down to get to that laminectomy, which let's talk about that now. So what I'd like you to do in lab is find the space on the vertebral column between the scapula. So kind of find C7 vertebral prominence, go between maybe L2, T2 to T6 or T1 to T5, 6, so kind of around there, about 6 inches long. In the midline, I want you to cut right down the spinous processes, right through that area. Then you're going to cut away the musculature that's in this area, about 1 inch laterally on each side, on the top edge and the bottom edge of that incision. You're going to kind of reflect that back. And then I want you to cut away the musculature. Now, I don't want you to disrupt too much of the serratus. If we go back to this one, that serratus posterior superior, you can kind of reflect that back. Try not to mutilate here as we go through this, but just to separate these tissues. So you're going to cut away that musculature that's in the areas that you're looking down now at that lamina, that space between the spinous process and the transverse process, that posterior portion of that vertebral arch that we talked about. And then you're going to use a chisel and a hammer and kind of cutting. You're going to cut through and chip through the lamina on each side to expose the vertebral column and eventually the spinal cord. You may need to use a nippers to kind of clean that up, or maybe you prefer to kind of use a nippers to kind of get at that lamina. Let me show you a cadaver picture here of what that's going to look like. So here is that transverse process coming down laterally. Here you can see that lamina has been cut beautifully. I want yours to look just like this. Only kidding. That's going to be really tough to do. But here you can see the bone of the vertebrae that's actually cut off here of that where that transverse process would go. So they've cut the lamina off here. Okay, now you're going to use that chisel and hammer to kind of get that off, and try to, again, like I said, try to leave the superficial muscles to identify it if you're able. Don't completely remove or destroy those overlying tissues, but do your best to get down there. Now, when you do get down there, we're going to start looking at the spinal cord. What's unique now, the first thing that you're going to look at when you see through the lamina is the dura mater. So you're not going to be able to see the spinal cord immediately. The first layer is this dura mater. Now that's the Greeks looked at this and said dura. That means tough. It's very tough. But it's mater means mother. So literally this translates tough mother. That's this layer right here. This dura mater. You're going to actually make an incision because you've opened up now. You can see this area. This is kind of what the window that you're going to be looking at. And you're going to open this up. So you're going to cut that dura mater, lift up with your hemostat, kind of lift up and gently cut, not too deep, but cut that dura mater up. And then you're going to reflect it back, doors kind of cutting at the top and bottom laterally, opening that dura laterally so you can see what's underneath it. What you'll notice here is the epidural space. That's just a term that you might want to, epi, above, dura, above the dura. In the cranium, what you'll learn though is that there is no epidural space in the cranium because the dura is actually adhered to the inside of the cranium. This is what makes it very difficult if you have a meningeal artery that's hemorrhaged. This is often fatal because that blood will just push into the brain tissue as it pools. Unless it's released by drilling through the skull, that can be very dangerous and very life-threatening. But the epidural space in the spinal cord is the space between, kind of around the vertebral column, but posterior to the spinal cord, but anterior to the spinous process, if you will. So this can be used for injections, that epidural space in anesthesia. You can inject between the vertebrae and kind of bathe this area, so anesthetic can kind of make its way laterally towards those spinal nerves. Or you can give a subdural injection going below the dura. So you can also have access to the cord by placing that injection kind of, if you're a nurse anesthetist or an anesthesiologist, you'll feel the needle kind of push through the dura. You'll feel a pop. And then you can inject it subdurally this way to get more into that subdural space for anesthesia. But epidural and subdural just are where that is in space. The next layer of the coverings is the arachnoid mater. Again, I believe that's Latin for the spider web looking layer here. This is a waterproof layer. The cerebrospinal fluid will be deep to this layer, so kind of bathing that spinal cord, the central nervous system there. And then the pia mater is actually intact with the spinal cord itself. It goes into the, like in the brain too. It goes over the gyri right into the sulci. It contours the structure. So here you can see the pia mater coming into these fissures here and around. The pia means tender, so the tender, gentle mother. Dura mater, tough mother, pia mater, tender mother. And then what I'd like you to see is kind of the organization of the spinal cord. So just a little review of that real quick before we wrap up here. You'll be able to see the dorsal root ganglia, the DRGs here. The dorsal root ganglia are just where the nerve cell bodies of primary afferents, these pseudo-unipolar neurons carrying afferent information from the periphery to the central nervous system. You'll be able to see that bulge on the sides here with the dorsal root ganglia. You'll also see the dorsal roots as they're coming from that dorsal root ganglia, coming around this way, giving sensory information where they'll synapse in the dorsal horn of the vertebral canal, of the spinal cord rather, right here. And then you'll be able to see the ventral roots. Obviously, this is looking anteriorly. Your body is prone, so we'll be able to look at that later. But the ventral roots coming this way back, where they'll join to make that spinal nerve back that way. So what you can do is actually take your hemostat and lift up the spinal cord. Let's go back to this picture here. You can actually take your hemostat and lift up that spinal cord and just be able to identify some of those things where you can see the dorsal roots here. You can see the ventral roots here. Here's a dorsal root ganglia. It's not quite as prominent as I think you'll be able to see. I think you should be able to see the dorsal root ganglia, the dorsal roots, the ventral roots coming anterior, the motor information coming back to that spinal nerve where they'll join. But you can also make a transverse cut, a transverse section through the spinal cord. And that will be able to help you identify, then you'll be able to see, looking down or up into the vertebral column, you should be able to see that gray and white matter, that patterning of the gray and white matter there. What you'll also be able to see is the dorsal rami coming off here. The dorsal rami, sensory information from and innervation to the deep muscles of the back and the trunk coming on each side. Here's just a different view of that. So here's the musculature between the spinous process and the transverse process that you've dissected off. And you've done this laminectomy. You've cut here, you've chiseled, you've taken off that spinous process in the lamina and exposed this inside portion. Here's the dorsal roots. Here's the dorsal root ganglia. Here's the ventral roots coming back. And then you've got this dorsal rami right here coming down this way backwards. So sensory information and motor sensory information from the musculature, motor innervation to the backside of the musculature there. And then you got the ventral rami. This is going to be the majority of it here. The ventral rami are actually going, that's what creates much of the plexuses. So the ventral sensation from an innervation to the sides of the body and the front of the body and the extremities. So the cervical plexus, the brachial plexus, around the thoracic cavity, those intercostal nerves, and then the lumbar and sacral plexuses as well. Those are all made up of these ventral rami coming down this way. Here you can see a little bit of the denticulate ligaments. Not really, probably easier to see it from here. These denticulate ligaments, these actually come extensions of the pia mater, so deep there, going through the arachnoid, through the dura, and it actually attaching to the bony structures of the vertebral column. So you can see the denticulate ligaments kind of holding that, stabilizing that spinal cord in place, anchoring it in place, if you will. Okay, go back to this picture. Maybe you can see the extensions of the ventral rami. Here you can see that gray, going towards the sympathetic trunk. Remember the sympathetic trunk? Here's a ganglia, the sympathetic trunk up here. So the white rami leaving that ventral ramus, coming down this way, kind of looping back is the gray rami coming back up. Other gray rami are going to go towards the organs to innervate the organs here, part of that autonomic nervous system that we talked about earlier in the abdominal cavity. Let's see, what else do I want to say here? Let's go to this picture. Here you can see two enlargements of the spinal cord. There's a cervical enlargement and a lumbar enlargement, and those are because of the brachial plexus coming out of the cervical spine, innervating the upper extremity, and the lumbar and sacral plexuses innervating the lower extremity coming down this way. So those enlargements down here at the lumbar and the cervical spine, lots of information, not only going around into the thoracic cavity, but also going down into the legs and down into the arms. So those enlargements there. You'll notice that the spinal cord ends right here at about the level of L2, L1. Above L2 is the end of the spinal cord, they say, roughly. That's pretty universal. So if you're going to, that conus medullaris, the bottom of that organization of the spinal cord. Below that, you've just got these threads. Those nerves aren't organized in that spinal cord fashion like you saw here. They're more just coming down, all those tracks, or all those individual nerves are coming down, and they call it the cauda equina, or the horse's tail. And you've already seen some of this. Remember, as you cut down, in your previous dissection, when you removed the limb, you cut over, probably on the left side, you went up and over, and it maybe exposed some of that cauda equina. I'll also have an example of the cauda equina in the lab for you to take a look at here. But when you do a lumbar puncture, if you're trying to test cerebral spinal fluid, it's usually done below L2. You'll bend way down, they'll puncture through the vertebrae, they'll kind of, let's go back up to maybe here. So you'll bend forward, maybe at L3, 4, you'll find the spinous processes here, L4, 5, you'll put the needle through and then puncture in toward that, into that vertebral column. Because you're less likely to damage or disrupt the structure of the spinal cord here, because it no longer has the integrity of the cord itself. It's more now just these, so you don't want to stab the cord. You can kind of, I imagine it's a little like trying to stab a noodle of spaghetti with a fork. It's tough to do. The structures are going to move around that needle as you're drawing out cerebral spinal fluid. So, okay, I think that's all I wanted to talk about. I look forward to talking to you in lab. I hope this was helpful. I hope you learned something, and I will see you in lab. Have a great day.